Inside the human brain, deep within a region called the basal ganglia, a very specific group of neurons produces dopamine. In Parkinson's disease, these dopaminergic neurons progressively die off, resulting in a severe, localized shortage of this crucial neurotransmitter. Because dopamine acts as the chemical messenger that coordinates smooth muscle movement, losing it leads directly to the physical hallmarks of Parkinson's: extreme stiffness, resting tremors, and an agonizingly slow execution of voluntary movement known as bradykinesia. Looking at this mechanical failure, the logical solution seems simple. If a patient is missing dopamine, you should be able to give them a pill containing dopamine to replace it. This diagram shows exactly why that doesn't work. Before any chemical in the bloodstream can reach the brain, it has to pass through a highly selective filtration membrane called the blood-brain barrier. Dopamine molecules are simply too large and structurally rigid to pass through, so they bounce right off the wall, leaving the motor circuits completely starved. To bypass the blockade, pharmacologists turn to a precursor molecule called levodopa. It is a biological building block that the body naturally converts into dopamine, and crucially, it is small enough to successfully slip through the blood-brain barrier. But administering levodopa creates a massive secondary problem. The human body is highly efficient at metabolism. Long before the levodopa ever reaches the brain, enzymes in the peripheral bloodstream start breaking it down, prematurely converting it into active dopamine. Having free-floating dopamine trapped in the systemic blood supply triggers severe, immediate reactions. Patients experience intense nausea, vomiting, and sharp, sudden drops in blood pressure. Taking levodopa on its own poisons the body without treating the brain. Most of the dose is destroyed in the blood, and the tiny fraction that does survive the journey isn't enough to relieve the physical stiffness and tremors. To make levodopa viable, it had to be paired with a mechanism to cheat the body's metabolic defenses. The result is co-careldopa, a precisely engineered two-part drug therapy built to protect the precursor on its journey. This visualization shows the primary active payload, levodopa. Its only job is to navigate the bloodstream and reach the brain intact. Right alongside it is the second component, carbidopa, functioning entirely as a molecular bodyguard. Instead of interacting with the brain, carbidopa molecules bind directly to metabolic enzymes in the bloodstream, allowing the levodopa payload to circulate freely. When they reach the destination, levodopa slips cleanly through the blood-brain barrier, while carbidopa is left behind. This exact separation maximizes the amount of dopamine generated inside the brain to restore movement, while simultaneously preventing the systemic nausea and hypotension that ruined the early treatments. Because the payload is delivered so efficiently, the clinical impact is rapid. When a patient takes an immediate release dose of co-careldopa, motor symptom relief typically kicks in within 30 to 60 minutes. This direct, rapid mechanism is why co-careldopa remains the gold standard therapy for restoring physical mobility. It actively replaces the missing chemical, allowing rigid muscles to relax and tremors to subside. Yet, managing a neurodegenerative disease with an oral medication is an ongoing physical challenge. Sustaining that mobility requires strict adherence to a daily dosing schedule, carefully balancing the drug's intake against the body's continuous metabolism. That daily management starts in the gut. Levodopa shares an absorption pathway with dietary proteins. If a patient takes their medication alongside a high-protein meal, the protein physically competes for absorption, severely delaying any relief from their stiffness. Physicians also have to screen out dangerous counter-medications. Certain antipsychotic drugs and anti-nausea medications actively block dopamine receptors. Prescribing them will neutralize the co-careldopa and immediately worsen the Parkinson's symptoms. Even standard blood pressure medications pose a threat. Because co-careldopa lowers blood pressure on its own, combining them creates an additive hypotensive effect, drastically increasing the patient's risk of severe dizziness and falls. Getting the dosage right requires balancing the patient's entire systemic chemical profile. A single misaligned prescription or poorly timed meal can completely unravel their motor control. This chart illustrates the greatest long-term hurdle. As Parkinson's progresses and dopaminergic neurons die, the brain loses its capacity to store dopamine. The therapeutic window shrinks. As drug levels fluctuate, patients fall into rigidity or spike up, triggering erratic movements called dyskinesias. To combat this instability, the medical regimen has to evolve. Specialists will meticulously titrate the co-careldopa doses and introduce add-on therapies to stretch out the drug's half-life and stabilize the fluctuating dopamine levels. Co-careldopa remains a medical marvel. It is a highly effective pharmacological anchor that restores years of independent mobility, but it is a therapy that must be constantly recalibrated, fighting to keep a fragile chemical balance against a relentlessly moving neurodegenerative target.